All right, cool. So we'll go ahead and get started here. Saving the best for last, obviously. This session on modeling and simulation part 2 here. So first up in this session, we're going to have Daniel talking about differentiable simulation for outcome-driven orthognathic surgery planning. Take it away.
Thank you for the introduction. So welcome to my talk on our recent work. In this paper, we're looking at an inverse problem in surgery planning. And in the specific case of orthognathic surgery, we look at how we can solve it with differentiable simulator, and in that way make treatment planning more quantitative and improve the quality of doctor-patient communication. So orthognathic surgery is, bear with me. Okay, orthognathic surgery is a surgery of the jaws of the face where they are cut and repositioned to a new location, which changes the facial profile and the dental occlusion. It's done in cases, for example, of overbite, and this is a before and after picture. The technical name for overbite is class 3. So you can see the effect on the profile is quite profound. It's also done for, sorry, that was underbite, this is overbite. It's also performed for facial asymmetries and traumatic injuries. And it has several benefits to the patients. So not only is it an aesthetic surgery, it also alleviates problems that occur from heavy malocclusions such as chewing problems, breathing difficulties, and chronic joint damage. So the question is, these are quite scary surgeries. How can we plan them accurately, effectively, and make the patient comfortable? The first step of planning is to gather the data. This includes a consultation, and the doctors then take medical scans, for example, 3D CT images and 3D face scans optionally. And this allows them to determine a broad goal of the treatment. After this, a specific goal is set. This includes the doctors identifying common medical landmarks on the face. And by comparing measurements between these landmarks to healthy reference values, they are able to determine the target positions of these landmarks after treatment. That's the point in gold that you see on the slide. And here's where we get to the inverse problem. So the inverse problem means how to determine the plan, that is, how much to cut the bones and where to move them, from the target. And currently, that's performed using surgeon expertise. They train for a long time, and they know how the face behaves for a given operation. Of course, the problem with that is every surgeon has a different level of experience. They will give you a different surgical plan, and there's no way to communicate the plan to the patient. So tools have been developed to verify these plans with simulation. And this is an area of research going back almost 2 decades. These models take a surgical plan and try to predict what the outcome will be. They share several similarities. So they mostly use the finite element method with simple hyperelastic material assumptions that turn out to be acceptably accurate. And they modeled the motion of the bones as a rigid transformation. Unfortunately, this still leaves us with an inverse problem, because even though now we have a prediction from a given treatment plan, what we would like to do is to be able to calculate the plan automatically from the treatment target. And just by setting an arbitrary input plan, there are no guarantees that the landmarks have been reached optimally. And if we want to refine the treatment plan, we have to use manual iteration, a sort of open loop surgeon in the loop control, and surgeons don't like to spend a lot of time doing this. So they will usually do 1 or 2 iterations and then call it a day. And our method proposes to address this. So our simulation mesh spans the facial soft tissues between the skin and the skull. And we use a simple simulation energy that includes an elastic term for the deformation of the tetrahedra, as well as an active term that allows us to model the effect of the surgery. And what this does is it pulls the vertices on the bone towards their post-treatment location. It's as if they were attached by zero rest length springs, hence the visualization, and are being forced towards their post-treatment position. So we'll abbreviate these terms a little bit, and then note that the elastic term depends only on the deformed shape, whilst the active term depends on the deformed shape, but also the treatment parameters. Quickly, for formalities, I'll say that this is minimized with Newton's method, and we find the quasi-static equilibrium. That is our post-treatment shape. And now let's talk about what our treatment model is. So how do we determine the shape of the bones post-treatment? We set up a blend shape model for this, where using a surgeon's supervision, we have authored several meshes that correspond to the usually seen clinical deformations of the skull. And this allows us to combine them in a way that yields a post-treatment skull for a combination of these parameters. But I'd like to stress that our treatment model is not a critical part of our work. And in fact, it can be replaced with other models. What's critical is that it is differentiable with respect to the parameters. What this allows us to do is to calculate the gradients of the simulation. And using the fact that the nodal forces must be equal to 0 at the equilibrium state for any configuration of parameters, we're able to use this invariant to derive the gradients of the vertices with respect to the parameters. And using this information, we can then optimize the treatment parameters in the following way. So we start with a simulation mesh. And as seen before, we can plan the surgery using the traditional technique. And with our treatment model, we have a parametrized treatment that can be simulated. This gives us a prediction X of P. Now we can compare our treatment targets to the predicted outcome. And we use a simple point-based distance loss, which is trivially differentiable with respect to the outcome. And thanks to our differentiable simulator, we can propagate that gradient back to the parameters and use your favorite optimization techniques to minimize the objective function. For details, see the paper. We use a second order sparse Gauss-Newton optimizer, but really anything will work. And so with that out of the way, let's have a look at our experiments. So what we've done is we've created artificial deformed meshes and done that with surgeon supervision to mimic the common malocclusions. And then with a different surgeon's help, we have planned what the surgical goals should be. And that allows us to run our optimization pipeline. So what we can see from that is that the deformed maloccluded facial surface will be optimized towards the healthy surface determined by the treatment targets. And you can see the change from before to after in this animation. Here is another case. And quantitatively, we can see that the distance to the target landmarks decreases substantially after our optimization. And that the healthy facial profile is recovered. This is not the only interesting application of differentiable simulation. So using the gradient or so-called sensitivity matrix derived before, we can create linear approximations to a deformed equilibrium state. And for a modest pre-computation of the sensitivity matrix, we're able to interactively generate deformed states, which can benefit doctor-patient communication by visualizing rapidly what changes in the parameters due to the facial profile. And here is an example where we vary one parameter along the anterior and inferior deformation axes of the mandible. And it looks roughly like this. We can also combine the effects of the parameters into more complex deformations. So here we vary both the parameters at the same time. And comparing this to the true equilibrium state, we can measure the error between the prediction and the actual simulation results, and see that it is, even for this extreme deformation, extreme in the sense of clinically achievable results, it's still quite accurate, up to 3 millimeters at the sides of the face. So our work is still a prototype, and there's a lot to be done to increase the fidelity and adapt it to the clinics. This is mainly divided, in my opinion, into graphical and clinical improvements. So let's have a look at some of them. One of the most important ones is including important physical effects, such as contact simulation of contact between teeth and lips in themselves. This is important to generate realistic deformations and to make sure that the treatment plan is accurate. From a graphical perspective, we would like to see further work done on animation to make the avatars more realistic and be able to communicate the post-treatment state of the face better, as well as avatar generation, such that preparing the simulation meshes and the renderings takes less work for the doctor and is more realistic. On the clinical side of things, there is a lot of interesting work to be done on the treatment parametrization. So our blend shape model is only an initial approach, and work could be done to look at making it robust to all the kinds of surgical deformations that you see in practice, as well as other work to be done on more clinical effects. So models of tissue cutting, which could optimize the position where the bone is cut, or models of damage that include the anatomy, such as blood vessels and nerves, and are able to quantify the risk involved with a given surgical plan. So in toto, what we've looked at is an inverse problem in surgery planning, and we're able to solve it using a differentiable simulation. Our hope for this work is that it will be able to yield more quantitative planning and improve the quality of doctor-patient communication in the future. Thank you for listening. I will now take questions.
Thanks, Daniel. Questions for Daniel?
Yeah, thanks for the talk. Very interesting. My question is about you basically have one single goal or one single final position you want to achieve. Is that typically when they plan these treatments, or do they also take into account, for example, how the face is going to look when they open the mouth and that kind of stuff?
Mm-hmm.
And Yeah.
That's a very interesting question. So typically in clinical planning, they will just have one target from the neutral position of the face. But of course, it would be very interesting to look at how that face behaves when it's smiling, or to consider a wider spectrum of possible achievable goals in case the plan isn't perfect and the outcome is a bit different.
There's a question.
So, this surgery is very interesting. So you mentioned it in the limitation of the future work. You can't cut it straight away in the jaw because you have nerves going and like you just cut the nerve, like you lose sensitivity. So you have to take into account like some biological constraints. So how would you do like to first scan all the nerve, replace them, and like figure out how to cut around?
So that is a challenging problem. Currently what's done is that the doctor identifies those structures in the medical images, so the CT scans, and then there are surgical techniques that are designed to avoid damaging those structures, specific shapes of the cuts. And in order to automate that, we would need to be able to segment those structures, identify where they are, and then parametrize the surgical plans in such a way that they're able to place the cuts and not intersect or damage those structures.
We'll take one more question.
Yeah, great talk. I'm interested in the visualization side of things. So, or like the modeling, let's say. So we see there's bones, there's skin, there's teeth as well. How do you model all of these things? Like two-dimensional stuff or rigid bodies or?
So in the simulation model, we have the volumetrized domain between the skin and the bones, and that's spanned by linear tetrahedra. We don't currently take into account the skin and bone surfaces, but they could be modeled in future works with, for example, the surface triangles with a given stiffness.
Right, so then the bone is prescribed, basically. Like it's not simulated as a rigid body, it's prescribed. So it moves and then the soft mesh.
Yeah, the
follows
soft
it.
mesh follows it.
Okay.
This is roughly accurate to the reality because the bone is so much stiffer than the soft tissue and it can be cut arbitrarily.
Okay, yeah, and then the second question you allowed is how do you validate this actually? I was curious, like how did you said it's accurate, right? So, but you need to find the materials, right?
Right. So
It's also the visualization, like how many right that you need, where in the how do you go?
That is a lot of work to be done if we want to take this to clinical application. And in that case, you need to have before and after treatment scans. We don't do that here. This is a proof of concept that the optimization technique can yield realistic results. If we wanted to validate it, we would need those data, and we would need to set up the experiments in such a way that we can compare the before and after. In that case, there's a lot of orthogonal literature that looks at doing this to make it more accurate, to select the right treatment materials, and get closer to physical reality.
Great, thank you. Anybody else?
All right, thanks again, Daniel, and we'll move on to the next talk. Thank you.
Thank you very much.